Assalamu alaikum. Good morning, everybody. Thanks, Mr. Chairman, for the nice introduction, and I want to thank the organizer for this great meeting, and thanks Vertex for arranging this satellite symposium. So in the next 20 minutes, I will talk about identifying sickle cell disease and transfusion-dependent thalassemia advanced therapy. So actually, this is my disclosure. And before that, like just for 10 seconds, you can scan the QR code. This is like pre-event survey. So as we know, like in early life, actually hemoglobin F is the major hemoglobin, and actually which contain like 2 alpha and 2 gamma. Actually, once the transition happen, actually after 6 months and from gamma to beta, you can see there is increased production of hemoglobin A. And this actually when the symptoms start if the patient is having thalassemia or sickle cell anemia. And it was mentioned, actually showed that like earlier before the era of hydroxyurea, if the patient is having hemoglobin F more than 8.6, better overall survival compared if they have lower actually hemoglobin F. And this is also, you can see any patient with sickle cell anemia, if the hemoglobin level actually is trending, is higher, actually they meant to have like lower symptoms, and even with thalassemia, they'll have lower transfusion, blood transfusion. So is there any way to increase this hemoglobin F? Actually, there is a new modality of advanced therapy, which is the gene therapy. So there is 2 mechanisms in gene therapy, actually. One is what we call it gene addition. The other mechanism is gene editing. So in both techniques, actually, they will screen the patient, and once the patient is eligible for this therapy, you will collect the stem cells. Then either you have the gene editing, or we'll talk about detail later on, or gene addition. So after the manufacturing, the stem cell is actually it's ready, then your patient will be underwent conditioning regimen and infuse the cells and waiting until engraftment. So in gene addition, actually so you collect the stem cells, there is a lentivirus. So you inserted this lentivirus. This will lead to production of modified beta globin. So the modified beta globin actually, if you can see here, actually it's unpolymerized hemoglobin, so this will lead normal red blood cells and no sicklings. This is in gene addition. So what about gene editing? So gene editing, actually, you don't add any lentivirus. Actually, you put what we call Cas9 and guide RNA. This actually will be enhanced in the DNA. The main reason, actually, the way this one gonna work, actually, by suppressing what we call PCL11A, which is important in suppression of hemoglobin F. That's why by doing gene editing, you inhibit this BCL11A, which leads to increased production of hemoglobin F. So this, as I mentioned the previous, so usually by doing the gene editing, so you suppress actually BCL11, and this leads to increased production of hemoglobin F, so the patient's symptom will improve. So let's now talk about the data about gene actually editing. So let's start with the sickle cell disease. Actually, so this is like a phase 3 trial. And you can see before talking about the trial, this is like the patient journey. So you will collect the stem cells actually. Then you will do the gene editing until the product ready. Then you will give the conditioning therapy, which is actually myeloablative busulfan, infuse the XSL, and waiting until the count recovers, then discharge the patients. So they include around actually 44 patients. The primary endpoint was free of severe vaso-occlusive crisis in the 12 consecutive months. Secondary endpoint, free from inpatient hospitalization with severe form of vaso-occlusive crisis in the first consecutive months. What are the eligibility criteria, actually? So we'll talk in detail. So this is the eligibility criteria. So I want you to look at the age. So the age is like approved from 12 until 35 years. And the patient should be eligible for autologous transplant. The patient should have normal actually transcranial Doppler. So if the patient has actually high transcranial Doppler, they will usually be excluded. The patient should have a severe sickle cell disease, so at least 2 vaso-occlusive crises per year in the last 2 years. And actually, the patient should have beta BSS or PS 0 or beta S beta plus. And of course, the patient should be actually fit like for this therapy. Exclusion criteria, as I mentioned some. So if the patient actually having HLA match, actually at that time, this patient usually will be excluded. And of course, if the patient has alloimmunization to RBC, because we are giving myeloablative, so these types of patients require blood transfusion. So if the patient has like alloimmunization, there will be harm of the patient. That's why they were excluded. And of course, if the main reason of, or main idea of gene editing is to increase hemoglobin F. So if you have a patient with hemoglobin F, so this type of patient were excluded. And as mentioned earlier about like any abnormal transcranial Doppler or Moya disease not treated, usually were excluded from this trial. Other exclusion criteria, as like any criteria, any clinical trial, if the patient not fit actually for this receiving conditioning therapy, they will be excluded. So what is the result? So the primary endpoint, which is the patient to be free from actually vaso-occlusive crisis for 12 consecutive months, it's approached around 96.7% actually median duration around 22 months. And here you can see, so this is actually the blue dots from the attacks of vaso-occlusive crisis. And you can see here after XSL infusion, I say you can see the number of red, the blue dots decrease, so the number actually of vaso-occlusive crisis decrease. And what about the second endpoint, which is the hospitalization? Actually, you can see 100% approach. This is secondary endpoint. And you can see also the blue dots represent actually the hospitalization. You can see all the patients, they will actually didn't require any hospitalization, which is the major issue with sickle cell disease with the current vaso-occlusive crisis. So what about the transfusion-dependent thalassemia? So actually, there's another study, which is a phase 3 study actually. And the inclusion criteria, I'll talk details about it in the next slide. But the primary endpoint is transfusion dependent for 12 consecutive months. Secondary endpoint, transfusion dependent for 6 consecutive months. So what are the eligibility criteria? Again, the age should be like 1253 with good performance status. And this actually in this trial, they include the patient with homozygous B thalassemia. Initially, they exclude beta-0 genotype, but later on, actually, these types of patients were included. And also, the patient should be transfusion dependent at least 10 units per year for the last 2 years. Exclusion criteria, the same. If the patient is having match-related donor, this patient will be excluded. Associated alpha thalassemia and alpha-1 chain, also these types of patients will be excluded. And I mentioned beta-0 were excluded initially. Other exclusion criteria are about the performance, so it's the same like any other clinical trial. So what are the results of the primary endpoint, which is like to be transfusion dependent for 12 consecutive months, actually it reached around, in 92% actually of the patients. So you can see here actually, so only like there's 3 patients, actually they not achieve the primary endpoint, but these 3 patients actually achieved this primary endpoint at actually at 14 and 12 and 21 months. So at the end, even there is a late response, they did well to be transfusion dependent. This is just to show us there is persistence of hemoglobin F after XSL infusion in patients with transfusion-dependent thalassemia. So now I give you the data about the benefit or the outcome from the doing XSL. So the question now, you have the allogenic stem cell transplant and the gene therapy. So which we'll use actually. So this is actually the journey or the treatment plan for any patient with hemoglobinopathies. Usually prevent any symptoms, symptomatic therapy, pharmacological transfusion, and the only way to cure these types of patients is allogenic stem cell transplant. Having said that, so we know sometimes difficult to find match-related donor for patients with hemoglobinopathies. And even if we find a match-related donor, we know one of the complications of allogenic stem cell transplant is the graft versus host disease, which is a major concern for the patients. And this actually is increased if the patient actually is having either unrelated or haplo donor. So, and you know, because there is risk of GVHD, usually we need to give the patient immunosuppressive medication. That's why we maybe increase risk of infection. So in gene therapy, actually, which is because it's autologous, there is no actually eliminate the possibility of graft versus host disease, and no need to identify a donor. So this is just the same thing as I mentioned before. So here, just to address that, in gene therapy, actually, there is no GVHD, no need for donor, no graft failure. The only concern is usually we give myeloablative regimen. The other thing is the long-term follow-up that is required about the safety of this gene therapy. Here, actually, this is just to compare between allogenic stem cell transplant and gene therapy, and you can see, and actually regarding in the median time neutrophil and platelet engraftment, there is no significant difference, which is not a major issue. I think the thing that you have to look at regarding treatment-related mortality, with around almost 6% compared to 2% in gene therapy, graft failure, 0 in gene therapy, around 9% in allogenic transplant. Of course, acute GVHD, 0 with the gene therapy, around 18% in allogenic transplant. So what is the advantage and the limitation of the both allogenic and gene therapy? So for allogenic stem cell transplant, actually the established protocol, it's available most of the centers, actually covered by the insurance. The limitation, as I mentioned earlier, identifying the donor, the cost actually for the follow-up of the patient after allogenic stem cell transplant, and it's need lifelong management. And about the gene therapy, the advantage is age flexibility, no need to identify any donor. The limitation is upfront cost. It's not cheap, it's expensive medications, and still it's need a lot of preparation for collection the stem cell and do the gene editing, and of course the limitation need also longer follow-up. So actually there is a specialized working group, an EBMT, which is this already addressed this issue before. But this is actually the recommendation. So if you have a patient, actually, in case of sickle cell anemia, if you have a patient with hemoglobin SS or hemoglobin S beta 0 genotype, actually, and there is an identified donor, you will take the patient for allogenic transplant. If there is no identified donor and the patient age should be above 12 years, this patient actually will be referred for gene therapy, and if will be assessed. If the patient actually is fit, they can proceed for the gene therapy. And this is the inclusion criteria. So in general, as I mentioned, hemoglobin SS or hemoglobin S beta 0, hemoglobin less than 30, no identified donor. So if you find a match-related donor, you will go for allogenic transplant. And of course, you need monitoring for these types of patients. And here there's general recommendation about each condition actually. So for vaso-occlusive crisis, it should be at least 2 vaso-occlusive crises required hospitalization per 2 years, recurrent acute chest syndrome. Cardiovascular system, we know the patient with sickle cell disease, they're at risk of cardiomyopathy. So they mentioned if diastolic dysfunction actually, in the absence of restrictive myocardiopathy, this patient actually can be eligible for gene therapy. Pulmonary hypertension should be between 25 and 29. And liver disease, actually, if there is this patient have chronic cholestatic hepatitis without hepatic failure, this type of patient will be eligible for gene therapy. Kidney disease, cerebral vascular disease, we know this types of patients were initially excluded from the trial, but they put actually here recommendation. If the patient has abnormal transcatheter Doppler, still you can take the patients, but I think to the gene therapy, we need to discuss with the patient about the benefit and toxicity. Alloimmunization, also one of the exclusion criteria in the previous clinical trial. Still, they mentioned you can use if the patient has alloimmunization, it can be eligible for gene therapy. Thrombophilia screen, if the patient has actually low risk of thrombophilia or the patient has thrombosis, and you can interrupt the anticoagulation, still you can take this type of patient gene therapy. Autoimmune disease, not contraindication for gene therapy. So we need a monitoring. Of course, this recommendation, any patient going for any therapy, they need a follow-up, either short-term or long-term. So, and this is actually, we know that patients with allogenic stem cell transplant are at risk to develop cardiac disease, pulmonary toxicity, and also affect the fertility. But these things that you have to keep it in your mind. This is actually their recommendations. So usually you're worried in gene therapy, as I mentioned, about the myeloablative conditioning with the toxicity. There is genomic editing tools that can be done. So the concern, like, is there any risk of malignancy in the future, actually? So because it was mentioned with the gene editing actually adding, there is like 2 cases of develop actually 2 sickle cell patients with gene addition develop MDS and leukemia. But that's why it was stopped. So, and they mentioned actually the acute myeloid leukemia could be related also to busulfan, which is the conditioning regimen that you give it to the patients. One thing, as I mentioned, is like the long-term follow-up of the gene therapies needed. And this is actually they mentioned actually there is a marker for poor prognosis, and this type of patient should be actually referred for gene therapy. As I mentioned, hemoglobin SS, hemoglobin S beta 0, lower fetal hemoglobin, and absence of alpha thalassemia, and some non-genetic factor like anemia and abnormal kidney disease. And I think by this I conclude. This is just a post-event survey. You can take QR code, and thank you.